I'd like to introduce myself. My name is Bobbi Reinholdt, and I'm the divisional lead for the new e-Prescribing division of Canada Health Infoway. I'm your moderator for this session, and I was kidding saying, and now for something completely different, because we are changing gears a bit. Hopefully you'll find this session quite meaty, so we are going back to presentation style. Our three panelists will make presentations, and then we'll open it up for questions and answers. So you know, today you can't read the newspaper or watch the news without hearing about the current opioid crisis. Opioid abuse is taking a heavy toll, not only here at home, but also internationally. The panelists are here today to discuss the current crisis and how initiatives such as e-prescribing can be part of the go-forward action plan. So what I'd like to do now is ask the panelists to introduce themselves.
So my name is Beth Sproule, and I'm a pharmacist, clinician-scientist with both the Centre for Addiction and Mental Health here in Toronto and the Faculty of Pharmacy at U of T. My background is both community pharmacy and hospital practice, and that's what got me into my research, my primary research area, which is in the prescription drug abuse area, which a lot of the focus has been on opioids.
Hi, my name is Josh Vinciguerra. I'm the director of the Bureau of Narcotic Enforcement with the New York State Department of Health. I'm a lawyer and a former prosecutor.
G'day, good afternoon. My name is Mike Hamilton. I'm physician lead at the Institute for Safe Medication Practices Canada, but I'm also a family doctor who prescribes, so I make a lot of the same mistakes that I try and protect everybody else against. So thanks for having me today.
So our first speaker, Beth. Beth and I have a lot in common. We're both pharmacists. We both graduated in 1984 from U of T. The only difference is Beth is a doctor and I'm not, and Beth's going to speak to you now, and I'm not.
Okay, so I was asked today to talk about prescription monitoring programs and within the context of the opioid crisis. And so because I'm going first, I thought I would just set the scene around what is going on with opioids, why it's so important, why it's been considered a crisis, and then how in Canada and more broadly, sort of using prescription records for prescription monitoring, how that fits in and how we think it might be helpful, and then sort of segueing into a little bit about then how e-prescribing might fit in with that. So the first slide is just kind of setting the scene to convince you that there has been a big increase in consumption of opioids, prescribed opioids worldwide. That's what this figure shows from 1994 to 2013, the steady increase, and we're hoping that it's leveling out, but there's been a steady increase over time. With respect to where Canada fits, this shows using International Narcotics Control Board data, that Canada has ranked second for quite a while, second to the US in opioid consumption per capita. The data goes out for like 200 countries, so we're second out of a lot of countries. And so we're known to be one of the high consumers of opioids, prescribed opioids. And why this is important, I think, is summarized really well in this graph. Because it shows the green line, you can see from 1999 to 2010 at this point, shows, again, that increase in opioid availability, this time measured as kilograms of opioids sold. But you can see the parallel lines for the two key harms that are associated with opioids, that of death from overdose and the risk of addiction, and in this case shown as admission for treatment for opioid problems. So you can see that they're rising in parallel. As availability increases, the problems increase. And so bringing it back to Ontario, what we know is that it's been happening here as well. So on the left side of this slide is a study that was done here, again showing the increase from 1991 to 2004 of the increase in opioid-related deaths in Ontario. But what I thought was really interesting about this paper was the relationship between those deaths and the healthcare system and prescribing. And so with those people, there was a high percentage of engagement with physicians and pharmacists prior to the death. And that's what it showed, that over half had at least one physician visit within 4 weeks, or emergency room visit for mental health or pain problems. And there was only a median of 11 days between that physician visit and the subsequent death. Likewise, with pharmacies and pharmacists, over half had had a prescription filled within the previous month, and they'd had a median of 10 prescriptions in the past year. So they are seeing physicians, they're seeing pharmacists, they're getting prescribed, getting dispensed, and then they're dying. Okay? So it really highlights the issue. So what I wanted to show is just kind of a schema of how I think it helps to show how prescriptions kind of fit in with the problem. So prescriptions for opioids can be used, and they're prescribed for therapeutic reasons and can be used therapeutically, but they can also be used for just recreational purposes. But I want to emphasize that these aren't kind of dichotomous groups of people, that people can go back and forth whether they're using it for pain or using it otherwise. There can be overlap in people who need it for pain, also having a problem with it or using it recreationally. And whether you're using it therapeutically or, quote, recreationally, the risks are the same. The risk of overdose and development of addiction are there regardless. And so that's why it's so important. So prescriptions are written, the intention is for use therapeutically. But prescriptions could also be filled based on scams, of course, people feigning pain and getting prescriptions, or from double doctoring, and that can be people from scamming, or people who have pain but still going to multiple doctors to get more drug, or just cutting out the physician completely and having forgeries. Or people who are getting prescriptions for their own therapeutic purposes can sell or share their prescriptions as well. So all of these, the proportion, most prescribing is for therapeutic purposes, for short term, for people who have pain, but the numbers of people where the problems of addiction and overdose has been increasing, and that's why we're calling it a crisis, and why we have so much attention and so many initiatives happening right now. So this has been recognized for a while in Canada. We have something called the First Do No Harm strategy, which came out in 2013, which has 58 recommendations that span kind of 5 themes around prevention, education of healthcare professionals around this problem, treatment for opioid addiction, methadone, buprenorphine, monitoring and surveillance and enforcement. And so I was involved with the monitoring and surveillance piece, and as a pharmacist, that's what really got me interested, both from seeing these problems clinically and how can prescription records kind of contribute or help in understanding this problem. So the goals of prescription opioid surveillance are really to know what's sort of going on and tracking patterns of prescription to be able to identify potentially misuse and also the harms associated with that use. And so the reason for that is then to be able to identify interventions that might help, track whether the interventions are working, and it's kind of a circular initiative. Canada doesn't have or hasn't had a national surveillance program. We don't have the same kind of data sources that they have in the States, for example. But about a year and a half ago, the CIHI was charged with developing some sort of surveillance system for the prescription drug abuse area. And so they've been working hard and having a lot of consultations, determining indicators, determining what data sources they can use. And so we're really looking forward to that coming to fruition to help inform us. But there's a lot of different surveillance targets that can be incorporated into that kind of a surveillance system, where on the left are the sort of outcomes that could be measured, and then the types of things that could be reported on to help inform those. So whether it's the rates of prescription forgeries, or poison center calls, or treatment episodes, people seeking treatment. The one that we're focusing on today, though, is the use of prescription records to help inform what's going on. So by looking at prescription records, there's several things that are generally the target of trying to interpret what's going on with what's being prescribed and how often and to whom. And so looking at prescribed use, just the patterns and frequencies, but also trying to identify risky prescribing and risky use by patients, and then also looking at diversion, double doctoring, polypharmacy, that type of thing. So that's just sort of looking at the data. But it's one thing to kind of know what these patterns are, but if you actually want to use that data for interventions, then that's what we call a prescription monitoring program. So the program idea is that there's some structure around how to utilize that information to help intervene and reduce the problem. And so those interventions can happen at a couple of different levels. One is at the clinical level or the clinician level, and so that's where the point of care kind of real-time access to this information can be helpful in making decisions in the moment. So whether to prescribe, whether to dispense, having access to what else the person has had, what their situation is, can be thought to be very helpful information. But then at the program level, looking at the information kind of retrospectively, so the prescription's been dispensed, and looking at the patterns retrospectively, again, identifying people who could be reported to physicians or pharmacists, reported to regulatory bodies, or just sending out messages to the physicians, do you realize that you're an outlier compared to your peers? The letters to patients, some jurisdictions also do, flagging potentially problematic use. Also, real-time alerts to that sometimes the system, instead of forcing or relying on clinicians going in and looking at the data, sending alerts to it. And that's in Ontario with our narcotics monitoring system. We don't have real-time access to look at profiles, but there are alerts that are sent flagging certain, going to 3 pharmacies within a month, that type of thing for a monitored drug. And so then referrals to regulatory or enforcement bodies are quite common in prescription monitoring programs, or a common feature. But every prescription monitoring program is very different, including across Canada, the structure, how many interventions, types of interventions, what they use for definitions for identifying risky prescribing. It's all over the map for all of this. So this concept is kind of the what holds it together as being called a prescription monitoring program. So just to put it into context, the prescription monitoring program is basically kind of a subset of the prescription data because it's focusing on the monitored drugs, which are usually controlled substances or sometimes other substances that have the potential to be abused or cause problems. The other kinds of prescription record data that are often looked at are from third-party payers, where that again is a subset of the prescription data. It only includes things that are part of what they cover under their drug plans. But they have some different levers that they can use for interventions, such as not covering the cost of the drugs and trying to manage prescribing that way. And so both of those are examples of kind of subsets of prescription data. But the large data set, the full data set, are drug information systems, which several provinces do have now, that generally include all drugs, and often you do have real-time access or able to look at full patient profiles. So the last couple of slides I have is just sort of trying to bring in the e-prescribing piece to this, which is on the right, you still have that dispensing information. So that's kind of the drug information systems that I'm talking about. And potentially with e-prescribing, then you're going to have a prescribing information system. So another set of data that reflects the actual prescribing and not just dispense data. And so the prescriber then prescribes, that information goes into the system, and then the pharmacist receives it and then dispenses it, and it goes into that system. And so really the question is, how does this then, may it help, or how could it influence, or how does it fit in with this picture around monitoring? But just before that, I want to make a point as a pharmacist that they really need, especially when we're talking about the opioid problem, they really need to talk to each other, have common goals, each other needs to know and be informed of what the plan is, what the goal is with the patient, and then how you retrieve the prescription is secondary. But what can happen potentially, and this was just me sort of brainstorming and not, we don't actually have e-prescribing system to comment specifically on how this might work, but the idea is that at point of care then, the idea would be that both prescribers and pharmacists can have access to patient profiles to help. And the idea is that potentially, if you have access to the prescribing information, not just of what you're prescribing, but if the system allows to have information about what else has been prescribed to the patient, then that can help prevent things like double doctoring and help inform prescribing. as the dispensing information system can also help with reducing double doctoring and polypharmacy, for example. Certainly, we're hoping that with the e-prescribing system that you kind of really reduce or cut out the forgery situation completely, because then it's more difficult to do that. But what's important is that whatever system that this comes in, we know that to make it work, it has to be easy to access the profiles. You need to be able to have it, again, integrated into the workflow so that there's not sort of a separate system clinicians log into. We know mostly from data from the States, actually, that there was a problem around clinicians accessing the profiles, and there needed to be some mandating done to force clinicians to actually look at the data. And a lot of the studies have shown that it's really, there's an increased uptake, certainly, the easier it is and the more integrated it is into other electronic systems through your workflow. So then when looking at, these two repositories of information from a retrospective point of view, or looking back at what's happened, the question comes up around, is there advantages over looking at a prescribed database versus a dispensed database? And I think they can be complementary, but there are a couple of things to consider. One is for the prescribed one, for that to work, it really would need to be, and especially the point of care access, you would really need it to be universal. With dispensed data, already pharmacies do and need, and they're mandated to submit the information, for example, to the prescription monitoring programs. So unless all of the physicians and EHRs are doing the e-prescribing, then it makes it less useful that way. But on the plus side, the e-prescribing could be more timely if it's, when they prescribe it and then it's going to be in the repository right away. Then looking at that data could be more fulsome, versus with pharmacies still, there's a lot of variability in how quickly the information is actually uploaded and then would contribute to the patient profile information. But however, sort of comparing the databases could be useful from a research perspective and looking at the differences between what was prescribed or attempted to be prescribed versus what was dispensed, and a potential to look at what the differences are around what interventions might have played in that process and change the pattern that was actually dispensed. So those were my comments that I had, and I'll pass it along to the next.
Thanks, Beth. Well, there's been a lot of comments made earlier about people not knowing how they got here. But if you get a chance, I think you literally have to ask Josh how he got here. So there's a story there that I'm sure he'll share. Josh.
Thank you very much. And on behalf of Governor Cuomo and our Health Commissioner, Dr. Howard Zucker, I just also want to thank Canada Health Infoway for the invitation to join you here. It's great to be here, and it's a real honor for our state. What we went through in the beginning at the top of this is the same in New York State. The ruination of New Yorkers' lives by heroin and opioids has been horrific. Heroin overdoses were the leading cause of accidental death in New York State. From 2009 to 2013, opioid analgesic-related deaths increased by about 30%. And from 2009 to 2014, emergency department visits that were opioid analgesic related increased 73%. So we've had a major problem, and we've taken sort of a comprehensive approach in trying to fight it and to get it back under control. New York State had a prescription monitoring program since about the 1970s, but it was slow, it was horrendously underused, it was on paper, and in 2010 it went electronic, it was online. But it was still massively underused. Only about 5% of practitioners were using it. So in 2012, the Prescription Drug Reform Act was signed into law and made changes to the existing prescription monitoring program. We required that prescribers check it first before prescribing any Schedule 2, 3, and 4 controlled substances. And we required dispensers to report the data back to us of their dispensing of any controlled substance within 24 hours of dispensing. In addition, that law created the mandate for electronic prescribing of controlled and non-controlled substances in New York State. In addition, it established a work group of industry people and professionals and created a safe disposal program and unanimously passed both houses. Now, we have an official prescription program. That is that our state has an official prescription form that everyone's required to use when they do paper prescriptions, and there are built-in safety features as part of that. We were learning, though, that the scripts themselves, the blank scripts, had a street value of between $125 and $500 a piece. So each one has its own serial number on it, and from 2006 to 2015, we issued over 1.6 billion of these prescription forms at a cost of approximately $85 million. Huge expense. We also take responsibility for destroying the prescription forms when doctors retire or they turn over their licenses, they're no longer actively prescribing. So we will scan in returned scripts to us and shred them, so we have a record of those also. So for the timeline, just to give you a sense of how long this took, the law passed in August of 2012. We had passed regulations that became effective in March of 2013. And the mandate itself was supposed to go into effect 2 years after that on March 27th of 2015. We could see, and everybody could see, as we were gearing up to implement that mandate on that date, that a lot of practitioners weren't going to be ready. And it caused a lot of consternation, not just among the industries, among physicians and pharmacists alike, but with patients too. And so with the same idea of avoiding patient harm, the governor and the legislature got together and they said, okay, all right, time out. You can have one more year, and we'll do the mandate will now go into effect next year, March 27th of 2016. And so the rule is pretty straightforward. All prescriptions have to be electronic, but with a sweeping mandate of this kind, there have to be exceptions. So we created a series of exceptions to deal with the major things that we could foresee were going to be problems. The technological, electrical failure, if electronic prescribing was going to impact a patient's medical condition, you could prescribe a 5-day supply. If it was going to be issued by or if it was going to be dispensed outside of New York State, paper prescribing was fine. We couldn't require pharmacies outside of New York State to follow New York's rules. Veterinarians are exempt. And we created a waiver process as required by statute for some practitioners to be able to just continue to write on paper. So the exceptions now have to be noted in a patient's medical record when they're being used. And the reaction was still pretty intense. In the beginning, it was quiet. This was a ways off. This was years away from going into effect. So it was muted in the beginning. But we began to hear from practitioners, and a lot of them, saying, I can't do this, I don't know what to use, and you're going to make me retire because of this. This is awful. I'm leaving. And we didn't want to encourage that either. But as far as dealing with software and talking about what types of systems to use, really as a governmental agency, we weren't in a position of being able to endorse any particular kind of software to use. So we encouraged them to speak to their professional associations, talk to their colleagues. And by 2014, 2015, there were a lot of different programs, a lot of different kinds of software out there, and a lot of capabilities that are specifically tailored for every kind of practitioner, whether you were solo, working off your phone, working in a group practice, working in institutional settings. And so at this point, we can see that there was going to be a large capability on the part of industry to be able to respond and to supply what was needed to comply with the mandate. There were other situations in which we could see that certain groups weren't going to be ready. There were facilities and institutions that were undergoing mergers and had 4 or 5 different kinds of EMR systems that weren't conversant together yet. So they needed more time just to be able to get all of those things together. Nursing homes in New York State operate under a very different and particular process of prescribing, involving oral orders at times, written orders at times, and infrequent doctor visits to the actual facilities where they may be there on site once or twice a month. Pharmacies were ready, and the chains were great about this. They were almost 100% on board from the beginning. So when we were looking at the mandate that we were going to have, we had to review the federal rule that there is on electronic prescribing because our federal Drug Enforcement Administration has rules about the security of electronic prescribing for controlled substances. And so our requirement incorporated that software being used had to be compliant with the DEA rule. We had to develop the regulations, but what was more important than that was developing the outreach materials that we made for doctors, for patients, to explain to people what this was going to mean, how they would be able to continue to get their medications in a timely way, how they'd be able to shop around for drugs, even if it meant that they would have to look beforehand or they would have to wait to have their physician transmit a prescription until they knew where they wanted it to go. But the ability to shop was still going to be there. And we had an online and a paper registration process for practitioners to be able to register their software with us. So the requirements were, as we mentioned, following that DEA rule, and we also worked with several other state agencies and practitioners who were as part of that working group, able to give us input from the field about what this was going to take. Developing the waiver process was pretty key also, because it went a long way towards reassuring practitioners that they were going to be able to continue their practice and that their patients were going to be able to get their medications and that we were going to be reasonable about this. It doesn't matter how easy the form is, and we had a one-page waiver form to use. What was inducing the anxiety was the wait time between the time you submitted your request for a waiver from ePrescribing and the time that the Department of Health got back to you to tell you whether you were going to be able to use it or not. So what we tried to do was reassure people about the kinds of circumstances that we saw as being conducive to receiving a waiver. In terms of readiness, just the next couple of slides we're going to flash through. The numbers are very small to see, but we're starting in about November of 2014. The blue color represents the pharmacy readiness, and the orange represents providers. This is from courtesy of SureScripts. But in November of 2014, you can see that while the state was pretty dark blue in terms of pharmacy readiness, providers weren't quite caught up yet. And over time, this began to change to the point where we got to June of 2016, and we were looking at approximately 68% of practitioners who were now electronically prescribing pursuant to the DEA rule, had their software registered with us, and we're now up to about 71% there. And so that's what we're looking at, sort of that middle column there in terms of being EPCS enabled. That means they're following that DEA rule. In addition to the waiver process, though, we also had to look at the fact that there were going to be a lot of questions about this. We developed a frequently asked questions document of about 150 questions that we had online available. We had to set up a call center involving 3 or 4 people who were able to just field those sort of level 1 calls for physicians and patients who had questions about the mandate. And then there was intervening legislation that came in also that we had to adjust to. That legislation was for low-volume prescribers. And basically what that law said was anybody who certifies to the department, either in writing or electronically again, that they're going to do 25 or less prescriptions per year for controlled and non-controlled substances combined can be exempt from this. So we set up that certification process also, and we began taking on certifications from practitioners as well. This came in after the waiver process. So most practitioners who were looking to avoid electronic prescribing had already applied for a waiver, which was good for 1 year, and they'd received that. We received probably about 600 certifications from low-volume prescribers. With the waivers, we got about 6,200 waivers approved for about 38,000 practitioners. And again, that's the bulk of the practitioners who are not now electronically prescribing. And most of those are within institutional settings or with facilities that aren't necessarily electronically prescribing. Because our waiver process was location-specific, a lot of those 38,000 practitioners are e-prescribing individually or through their group practice, just not necessarily in their institutional setting. So it looks like a large number, and it is, but a lot of them are also electronically prescribing anyway. And our experience has been, just over the summer now, that a lot of the people who received waivers have gotten back to us and let us know, I'm e-prescribing now, I don't need the waiver anymore, thank you very much. But the waiver process was a very important one, and communicating with the professional groups and physicians themselves was important for that. There were other problems that we didn't foresee involving the technology and its ability to meet some of the needs of complicated prescribing issues. And so those included some on the list that you see here, involving compounding, involving long or complicated directions. The most electronic prescribing capability only gives you about 140 characters worth. It's Twitter-like level of information that you can put out there. So there are other situations that we wanted to address, and we did that with a letter from our commissioner basically waiving electronic prescribing requirements under those certain circumstances. And that letter is available with the full list at the link that you see there. So our phone call volume, just to give you a sense of that, went up pretty high in the weeks leading up to it, but then dropped off pretty regularly. And by the time we were down to mid-May, it was a much more manageable number of scripts. So what we'd recommend if you're considering doing this, and the other 49 states looked at us and said, okay, New York looks good on you, we'll see how this goes, is to reach out early and talk to the people that are going to be affected by this to see where they are in terms of readiness. And I think as the industry drives this as the standard of care, you're probably going to have a much better time with it in terms of readiness. The communication was the key. We'd probably recommend not starting that waiver process too soon, though, because you want to be able to ask your prescribers, okay, what are you doing to get ready? Like, it's great, like, we'll review the waiver, but what steps are you actively taking to get your practice ready to e-prescribe when the time comes? And then there's always the case that there can be some wildcard proposed legislation that comes in that you have to adjust to. Recognizing that not all practitioners were created equal, we took an approach with the applications that we got for our waivers to talk to practitioners, and we reached back out to them for additional information and said, okay, this is good, but can you help us understand your situation a little bit better? And we tried to recognize that everybody's circumstances were going to be a little bit different. The standards we had mentioned in the commissioner's letter, if you're working on those or you have federal ones at a national level that you can point to, as we did with the DEA, that's much more helpful. What we also found in terms of our numbers here, we were looking at just the way that it ramped up, and it really did seem like the bulk of prescribers were ready to go when the mandate came into play. At this point now, this is as of September 2016, New York State accounted for about half of the electronic prescribing of controlled substances in the nation, and about 13.2 million of the 116.6 million new electronic prescriptions in the country, or just over 11%. So what we have, at least one way of measuring sort of what's going on in terms of non-medical prescribing, is what we call doctor shopping, which sounded a lot like the double doctoring that you mentioned earlier. And how we measure that is basically a patient who goes, or a person who goes to 5 doctors and 5 pharmacies within 90 days. And what we had seen when the requirement to check the PMP went into effect was that over about the first 2 years of it, doctor shopping, as we called it, or the incidence of doctor shopping, had declined by about 90%. That was as of the first quarter of 2016. After that, with electronic prescribing starting on March 27th, we had the second quarter of 2016, and that number went down to 98%. So it was an 8% drop just in that one quarter, which was the biggest single quarter drop that we'd seen, basically since the mandate to check our prescription monitoring program had happened. Now, these are preliminary numbers, and we want to just keep our eye on that. But it looks like they've sustained through the third quarter of 2016 as well. So we're still down to about 98% of a decrease in our doctor shopping incidence. So we just wanted to keep this at a very high level at this point, but I will be around today and tomorrow and look forward to speaking to you more about this. And if you have any questions, I'm happy to talk. Thank you.
Thanks, Josh. Lots of lessons learned there, and I'm sure we're going to get lots of questions over the break. When we talk about opioid abuse, we need to talk about patient safety. So I'd like to invite up Dr. Michael Hamilton. I was trying to think of something quippy to say, but there's nothing funny about patient safety, so couldn't.
Yes, thank you. I've tried to find something, but it usually doesn't work. So thank you. This is me. We just met. I have no conflicts of interest to declare, no industry funding. I do prescribe opioids, as I mentioned, so I'm on sort of both sides of this. I'm with the Institute for Safe Medication Practices Canada, and really what we do in a nutshell is try and prevent the preventable harm from medications. Our sort of colleagues in France say éviter l'évitable, and that's avoid the avoidable, and that's really what we try to do. So thanks for having me. I'm going to start off with a few words about the historical context about this, about opioids. And controls on opioids have really been instituted traditionally to prevent misuse, diversion, theft and things like that. And if you think about if you're a clinician, the lock boxes that opioids get stored in, narcotics with other controlled substances, the 4 or 5 signatures that you need on narcotic control sheets, and the fact that sometimes you need special duplicate or triplicate forms to prescribe opioids, all of that is less about safety and more about the security of it. And I think it's important to keep that in context, because a lot of places security and safety overlap, but a lot of places they don't. And in my own institution, one of my nursing homes, their narcotic lockbox is terrible. It's horribly unsafe, but it's very secure. And so there's a difference, but I think we need to design systems going forward when we have the chance, like e-prescribing, to do safety and security together and not one at the expense of the other. And my other sort of context slide is that opioids is a big problem, and prescribing problems are a big problem, and patient safety is a big problem. E-prescribing is not the end in itself. It's not going to fix everything. We have a whole system designed to get medicines from the raw materials that you get into the patient's medicine cabinet, into their, however they take it. So manufacturing, labeling, all of this plays a part. And prescribing and e-prescribing is a very important part. And it's interesting, as I was thinking about this, that prescribing is probably one of the later things to ever get into the technological sphere. So we still do a lot of handwritten prescriptions in Canada, in Ontario, and elsewhere. And even if we think it's e-prescribing when we print our prescription out, it's still a piece of paper that the patient has to bring across the road or down the street to the pharmacy, and then the pharmacist or the pharmacy tech has to transcribe that. And that's, anytime you get a human involved, there's a risk of human-type errors. So if we can design e-prescribing systems that talk directly from electronic medical records directly into pharmacy records, we've come a long way in advancing safety. So some of you might be clinicians, prescribers, or pharmacists, and these prescriptions are the exact same thing. So this is 10 milligrams of morphine twice a day, and it's written probably about 10 or 12 different ways, and I might have thought of more, but I got bored and tired, and I ran out of room. And what I'm trying to demonstrate here with this in terms of prescribing is there's really no standard style to prescribe. There's no way we're mandated to prescribe. There's certain elements that have to be there, like a drug name, a drug dose, some rules about how you give it, mostly the route, although the route is often inferred by the drug, and a quantity. So required elements need to be there, but how you sort of arrange them in real life is sort of up to the prescriber. And all these are available in Canada. All these would be, probably happily dispensed by a pharmacist. And I think that, prescribing modules in EMRs, they kind of put a little bit of a restriction on it, but you can still free text a lot of things in most popular EMRs out there in Ontario today. And I think probably the number one thing is going to be the standardization of prescribing elements. So probably the most important thing when we think about e-prescribing is the standardization of all the elements, so that each discrete element in a prescription can be transmitted with the appropriate data field. And I think this is really going to help researchers like Beth and others sort of decide how we're doing as prescribing. And I'll talk a little bit about the difference between prescribing data and dispensing data a little bit later. One of the most important, I think, benefits of having these standardized fields, these standardized ways of writing prescriptions, is the calculation of morphine milligram equivalents or morphine equivalent dailies, however you want to put them. Now, there's lots of different types of opioids out there, and we sort of need a standard with which to compare them, and sort of traditionally we've used morphine. So all of these are 20 morphine milligram equivalents. So this is 20 milligrams of morphine every 24 hours. And we've done a lot of work in opioids, particularly with respect to safety and harm and risk of addiction and risk of overdose. And we know that the more morphine milligram equivalents you get per day, the higher risk of harm. So 20 MMEs is sort of low to moderate dose, but some of the more potent drugs like fentanyl patches and things, single fentanyl patch can be upwards of about 200 morphine equivalents a day. And it's important that we know this as prescribers, as even sort of in a social context, is that we need to know where we are prescribing. So if I prescribe one fentanyl patch, that may not sound like a lot, because it's 200 micrograms, which I know is a very small amount in a numeric sense, but it's actually extremely potent. And if I do that, I may not know where on the scale of morphine equivalents I actually fall. And you'd think maybe that EMRs, their computational power, I have a brand new computer, you think EMRs could easily calculate this automatically for me, but they can't because of the lack of standardization. We humans have natural language capability. We can able to process all this reasonably quickly. Computers can't. They can't do it reliably and they can't do it safely. So by e-prescribing, forcing physicians to write these rules and instructions and drugs in a particular manner is really going to allow for a better calculation of where people are in terms of the risk versus benefit ratio as their morphine milligram equivalents rise. Currently in most provincial prescription monitoring programs or drug information systems, a lot of the data comes from the pharmacy side, precisely because of that problem of, there's a million different ways to write a prescription. So it's easier to get it from pharmacy dispense data rather than prescribing data. But I think there's going to be a real interesting bunch of stuff to learn about prescribing data. Because we know that probably somewhere around 1/3 of prescriptions are never actually filled. So you get a prescription and you never actually cash it in at the pharmacy for various reasons. And that's probably pretty decent if you believe we overprescribe things anyway. And it's probably almost reassuring in a way if you think we overprescribe opioids. But it's not only about those drugs. There's good drugs out there that have good evidence to support excellent outcomes that just aren't being filled for whatever reason. And right now, as we've sort of set up the system, if I give a prescription to a patient and they don't fill it, no one really knows about it. I just assume that they have. The pharmacy, unless they actually have seen the prescription, is really not any wiser anyway. So, the dispense data is going to reflect that. The differences between dispensed and prescribed data, I think, is going to be very interesting, and I think we're going to have a lot to learn about that, and I'm going to be happy to spend some time thinking about this as we go forward. And with good standardized e-prescribed data with real proper fields where you can easily calculate morphine equivalents, you can do some really neat graphs like this. So this is from Tara Gomes, who's an Ontario researcher, and her group, and this was 2011, where they took dispense data, prescription dispense data, opioid data, on a per county level. And sort of the darker the county, the more opioid equivalents there are in this. And this is data from 2004 to 2006 that was published in 2011. So it took a little bit of time to compile this data, which was certainly historical in nature, but it still really provides some very interesting insight into prescribing habits. So if you have, or imagine you have, a robust e-prescribing system with these nice standardized fields that you can easily do these calculations, you could do this sort of map on an almost real-time basis so that you can track prescribing habits of people. You can track dispensed data from pharmacies. And that's going to help you, I have a public health degree, so that's going to help you on a public health side to really tailor interventions, even maybe on a neighborhood level, which I think would be terrific. And you can look at social programming in those areas. You can look at naloxone programs in those areas. You can alert EMS to say, in the past week, there's been a lot of dispensing of opioids. Keep on the lookout for overdoses and things like that. And I think because I'm with ISMP, I would be remiss if I didn't really focus a little bit on the safety benefits of e-prescribing. And certainly human transcribing, so moving information from one form to another, from one system to another through a human, is still one of the most problematic things we see in medication safety. And anything that moves this along or that reduces the need for humans to intervene is really going to advance safety. And I think the development of an e-prescribing system is really a great opportunity to engineer out some of the problematic ways that we prescribe as physicians. We use a lot of short forms that can be misinterpreted. HCT for hydrochlorothiazide, and some people will interpret that as hydrocortisone. We use acronyms that carry different meanings, like the MOS or the immediate release morphine, things like that I demonstrated earlier. We mix up our decimal points all the time. We use zeros when we should not use zeros, and we don't use zeros when we should use zeros. So as we develop these systems, these standards, we can force physicians or other prescribers into using proper terminology, into using proper form. And so really reduce the ambiguity and the little idiosyncrasies that physicians have when they prescribe. And certainly e-prescribing has terrific potential in medication reconciliation. Imagine having a real up-to-date list of your patient's medications. And I think with a robust and mature e-prescribing system, you can introduce what we've sort of termed a safety intelligence into it. And in particular, the point of prescribing, and Beth and Joshua had sort of alluded to that a little bit earlier about how you can have instant feedback about what your patient has had or what they've been recently prescribed. But on top of that, most EMRs have interaction checking, most pharmacy software has interaction checking, but it's only dependent upon what your current medication list is in that system right now. So if you imagine you could have interaction checking and allergy checking against all the other repositories of your own patient's information sort of around the system, you could really do a terrific safety net with that. And I think as we embark on e-prescribing, it's going to be a chance to really do what I think is really three things. Standardize how we communicate, particularly prescribers, drug information, and use that standardization to get really good data. And from that really good data, we're going to learn a lot about ourselves, how we prescribe, how people dispense, what patient behavior is in between those 2 points. And what we find, I think, is going to be really interesting. We also have an opportunity to build in more safety features, more enhancements, and I think all of these things are going to drive safety forward. Thanks.